Okay, I think we've got all the technical issues sorted. So welcome everybody, and thanks so much for sticking with us through the end of the day. We're really happy to have you all here. So today, this symposium is focused on sort of highlighting a number of ongoing empirical studies that seek to identify gaps in access to and use of mental health treatment and service use using sort of larger population-based data sets. My name is Vicki Fung. I'm from the Mongan Institute Health Policy Center, Massachusetts General Hospital. We've got 4 presenters, and then we're really grateful to have Sam Zuvakis here as our discussant. So I'm going to start us off with a presentation focused on the implementation of mental health care cost-sharing parity within the Medicare program. We have Michael Flores from the Cambridge Health Alliance, who's presenting complementary work from the same project but using a different data set focused on a slightly different population and comparison group. And then we'll have Nick Carson, also from the Cambridge Health Alliance, presenting some findings using the MEPS data, the Medical Expenditure Panel Survey, to look at disparities in follow-up after acute hospitalization for minority youth. And then lastly, we'll have Nicole Benson, also from Massachusetts General Hospital, presenting some work on sort of patterns of care in first episode psychosis using the Massachusetts all-payer claims data set. So we will have about 15 minutes per presenter, and I think just in the interest of time, we're going to hold all the questions until the end of the session. So hopefully you guys can all stick around till the end. And thanks very much to Agnes Rupp from NIMH for being here as our facilitator. So I will start us off and try to get us back on track a little bit in terms of time, so you guys won't be here too late. So I'm going to be talking about a study that we've got ongoing to try to understand the impact of implementing cost-sharing parity within the Medicare program on racial and ethnic disparities in mental health care. So this is an effort of a large collaborative team. I just want to acknowledge everybody on the team and our funding from NIMH. So we all know there are large and persistent disparities in the use of mental health treatment that sort of exceed what we see in general medical care. A lot of policy efforts to address sort of barriers to access to mental health treatment have focused on insurance parity. And a lot of the sort of larger federal legislation like MHPA and the ACA, which have focused on ensuring that insurance plans cover mental health services, they cover them at the same level and generosity as other types of medical services, and there are fewer barriers to receiving that type of care, have generally focused on the commercially insured population. To date, Medicare has been kind of exempt from some of those policy efforts. But in 2008, the Medicare Improvements for Patients and Providers Act implemented co-insurance parity within the Medicare program for the first time. So historically, because of limitations in the reimbursement for mental health services, beneficiaries would pay 50% co-insurance when they received mental health care, as compared with a 20% co-insurance rate for other types of services. So MHPA gradually phased in a co-insurance reduction from 50% to 20% between 2010 and 2014. So we know sort of from the rich parity literature that's out there that at least within commercially insured populations, parity is associated with reducing financial burden on patients without increasing mental health expenditures. There's less evidence on the impact of parity within Medicare beneficiaries and lower income populations who may have greater need for mental health care and may also face greater barriers to receiving that type of care. And there's also less sort of systematic evidence on the impact on racial and ethnic disparities in care. So we seek to examine the effects of the mental health cost-sharing parity implementation on use of mental health services for low-income Medicare beneficiaries. And then we assess whether the effects differed by race, ethnicity overall, and then we looked also at sort of where beneficiaries were receiving their care across different provider types. So we used Medicare claims data for a 50% sample of low-income beneficiaries. We used sort of a standard difference in difference approach to compare those who are exposed to the cost-sharing reduction to those who faced no cost-sharing throughout the study period because they were full subsidy dual eligibles. So our comparison group was this group of full subsidy duals or qualified Medicare beneficiaries who receive wraparound coverage for their Medicare cost sharing and therefore pay nothing out of pocket for their outpatient care. And then our comparison group were those who were just above the income eligibility thresholds for receiving the full cost-sharing subsidy. So there's no income data available in the Medicare enrollment files, but we identified folks who were receiving other types of subsidies that suggest that they're between 100 and 135% of the federal poverty level. So these are folks who are receiving the Part D low-income subsidy, or others with partial dual eligibility like SLIM-Bs. So our goal was to really try to identify a comparison group that was a little bit more similar with respect to income and potential need for care, clinical vulnerability as the comparison group of full subsidy duals. And because so this is just a sort of an illustration of the comparison groups and the cost sharing that they faced over the study period. So you can see in blue, the partial subsidy group is our exposure group. Their cost sharing decreased from 2008 and 2009 from 50% to 45% in 10 and 11 to 40% in 2012 and so on until 20% in 2014. And because of this, our difference in difference approach sort of looks at changes over time relative to 2008 in each year. So we didn't lump the whole post-policy period together. We wanted to look at sort of the incremental effects of the phase-in of the policy. We used the race ethnicity data that was included in the Medicare enrollment files. Our overall analyses include everybody in the sample, and then we also stratified some analyses by race, and we focused on Asian, Hispanic, Black, and white beneficiaries just based on sample size. Our outcome was to look at monthly mental health visit rates, which we identified using mental health diagnosis in the claim line, or a primary mental health diagnosis for outpatient facility visits. And then we looked across different provider types. So we looked at mental health visits to psychiatrists, non-physician providers, including psychologists, social workers, and PAs, primary care providers, and then facilities, including community health clinics and hospital outpatient departments. Our analysis used linear regression models. We included beneficiary level fixed effects to account for potential time invariant differences across our comparison groups. We also adjusted for some time varying covariates, including comorbidity scores. And then we included time trends at the hospital referral region level because of concerns about other concurrent policy changes that were going on at the same time that could have varied across geographic areas. So I won't spend too much time on this, but we had 2.7 million full subsidy beneficiaries and 735,000 partial subsidy beneficiaries. The majority of these beneficiaries were entitled to Medicare because of disability, and close to half of them were under 65. We had a fairly good representation of racial ethnic minorities, so there were about 40% of the sample amongst the full subsidy beneficiaries were minorities, and about 32% amongst the partial subsidy beneficiaries. As expected, both groups are sicker than average based on their HCC comorbidity scores, and the full subsidy beneficiaries were a little bit sicker on average compared with the partials. So this just shows the proportion of beneficiaries who had a mental health diagnosis at baseline. This is based on the Medicare Master Beneficiary Summary File and the CCW, the Chronic Condition Warehouse, flags for a number of different mental health diagnoses. So this indicates the proportion of beneficiaries in each of these groups that had a diagnosis as of 2007 or earlier. And I think consistent with what we were expecting, we see a high proportion of diagnosed mental illness amongst white beneficiaries. So 45% of the sample of white beneficiaries had any of the listed mental health diagnoses, compared with about 30% of Black and Hispanic beneficiaries and 17% of Asian beneficiaries. So I think there could be multiple things going on. One is potentially sort of the lower lifetime prevalence of mental illness amongst minorities. But also, if there's sort of reduced access amongst these populations, they're less likely to have a documented diagnosis in the record. In terms of baseline differences in mental health visit rates, just a couple of things to point out. So these show the mental health visit rates at baselines are stratified by provider type, by race, ethnicity, and by the subsidy group. So the full subsidy beneficiaries had higher baseline visit rates, mental health visit rates. And then white beneficiaries also had higher baseline visit rates compared with the other groups. White beneficiaries were more likely to have mental health visits with psychiatrists compared with the other groups. Black beneficiaries were more likely to seek mental health care from primary care providers, and Hispanic beneficiaries were more likely to get care from facilities and clinics. So here are the results of our main sort of difference in difference estimation. So overall, we found that the cost-sharing reduction was associated with an increase in relative visit rates for partial subsidy beneficiaries relative to the full subsidy beneficiaries in each year of the cost-sharing reduction. So you can see in the first bar is the change in relative visit rates in 2009 compared with 2008 for the partial versus full subsidy beneficiaries. And we don't see any significant difference here, which is what we would expect because 2009 was also a pre-policy year. So that was a nice sort of, I guess, falsification test or sort of validity check. Starting in 2010, as the cost sharing was started to be gradually reduced, we saw increases in mental health visit rates in each of the subsequent years on the order of about 2 to 4% over the baseline 2008 visit rates for the partials. We saw very different trends across the racial ethnic groups. So interestingly, we saw the largest and most consistent increases in visit rates amongst Hispanic beneficiaries. So that's that middle set of bars. Amongst Asian and Black beneficiaries, we saw initial increases in visit rates that eventually, though, petered out towards the end of the study period. Which is also when the cost-sharing reductions were the greatest. So this is a little bit puzzling and something that deserves a little bit more investigation. And then amongst white beneficiaries, we actually see the opposite. We don't really see much effect until the end of the implementation period in 2015, when we do see a slight increase in visit rates. Okay, so this is a busy slide, but hopefully you can kind of get the general idea. So this is stratified now by provider type. And we also see very different trends in terms of the relative changes in visit rates across the different provider groups by race ethnicity. So in the top left panel, these are mental health visit rates to psychiatrists. And we see with the cost-sharing reduction, there were increases in visit rates amongst Hispanic and white beneficiaries, but actually relative decreases for Black beneficiaries. In contrast, we see increases in visit rates to primary care providers for Black beneficiaries and fairly large increases in mental health visit rates to primary care providers. And then in the bottom left, we see really large increases in mental health visit rates to facilities and clinics for Hispanic beneficiaries. And then finally in the bottom right panel, we saw generally across the board relative decreases in visit rates to non-physician providers for partial versus full subsidy beneficiaries. And one thing to just keep in mind is that these are the difference in difference estimates. So actually, if you look at the unadjusted trends, visit rates to non-physician providers were sort of increasing overall over this time period, but they were increasing more slowly for partial subsidy beneficiaries compared with full subsidy beneficiaries. Okay, so in terms of limitations, obviously this is an observational sort of retrospective study. We are also limited in terms of what we have in the claims data. We don't have any information on Medigap coverage, which could have limited the cost-sharing exposure for partial subsidy beneficiaries. We also don't have any information on services that people might have sought on their own and paid for out of pocket, although this is a fairly low-income group who may not have as many resources to be able to do things like that. This is a period of dynamic policy change, so there are a number of concurrent policy changes that we're concerned about potentially impacting our results. A couple of big ones, though, we think would be more likely to bias our results towards the null. So for example, the ACA PCP payment bump and the increases in funding for federally qualified health centers may be more likely to increase access to care for the full subsidy beneficiaries relative to partials. And then, of course, there's a large ACA coverage increases, especially starting in 2014, which vary geographically, but which could have crowded out access to mental health services for Medicare beneficiaries. So our analyses try to address that by including HRR level time trends to try to capture, really just compare beneficiaries living within the same geographic area to account for that potential geographic variability. And then lastly, these analyses don't yet try to account for clinical need for mental health care. We were really interested in sort of overall changes in use Again, diagnoses may or may not be sort of a good indicator of actual need. I'll say that in sort of some of the analyses that we're doing right now, we've looked amongst the group that had a diagnosis at baseline, and the trends look very similar. But in conclusion, we found that mental health cost-sharing parity within the Medicare program was associated with about a 2 to 4% increase in mental health visit rates. Interestingly, we saw that although racial ethnic minorities had lower baseline mental health visit rates, the increases in visit rates were larger in terms of the associations with the cost-sharing reduction, and there were really large and sustained increases amongst Hispanic beneficiaries. The mental health care patterns vary substantially by provider type, and I think this is something we're really going to try to dig into in subsequent analyses, is especially trying to understand the increase in visits to psychiatrists for Hispanics and white beneficiaries, and the relative decline in visits to psychiatrists for Black beneficiaries, and also the really large increase in visits to PCPs. And I think this is something where we like to look sort of by clinical subgroups and try to also understand some quality process measures to look at the quality of care received in these different settings. So I think just in the end, it looks like the implementation of cost-sharing parity did seem to be associated with increases in use and could reduce disparities, especially for Hispanic relative to white beneficiaries. And our future work is going to try to understand changes in the quality of care as well as downstream outcomes like emergency department visits and hospitalizations to try to understand the impact on outcomes. Thanks. So I'll turn it over to Michael now, and then we'll take questions at the end.
All right, good afternoon, everyone. My name is Michael Flores, and today I'll be presenting findings from our study entitled The MIPA Coinsurance Reduction and Its Association with Mental Health Care Utilization. First off, I want to acknowledge some of our collaborators on this specific project, Benjamin Lee Cook, who is the primary author of the study, Dr. Rajan Sonic, Brian Mullen, Dr. Vicki Fung, who you just heard from, Dr. John Tu, Dr. Samuel Zavekis, and Dr. Joseph Newhouse. This study was funded by an NIMH R01 grant. So the high cost sharing for mental health services likely contributes to the low rates of access to mental health treatment for those with mental health illness in the United States. Between 30 to 50% of those with serious mental illness access any mental health care within a one-year period. Medicare beneficiaries have typically had higher cost sharing for mental health services than for other health care services. Starting in 2010, the Medicare Improvements for Patients and Provider Act, known as MIPA, phased out payment limitations on mental health treatment for Medicare beneficiaries. For beneficiaries receiving partial and no subsidies for their Medicare premiums, MIPA gradually reduced beneficiary coinsurance for mental health provider visits from 50% in 2009 to 45% in 2010, 40% in 2011 and 2012, 35% in 2013, and 20% in 2014. Prior studies on coinsurance parity have found that Medicare enrollees and health plans with health insurance parity for mental health and primary care had greater use of clinically appropriate mental health services following a psychiatric hospitalization. Studies on the Federal Employees Health Benefit Program in 2011 did not find any improvements on quality of care for those with major depression disorder. However, they did find a decrease on out-of-pocket spending for those with bipolar disorder, major depression, and adjustment disorder. Our objective is to the objective of this study was to evaluate the association of mental health cost-sharing parity in Medicare with out-of-pocket spending for behavioral health care and use of behavioral health care. We hypothesized that mental health cost-sharing parity will decrease out-of-pocket costs for behavioral health care services. We also hypothesized that mental health cost-sharing parity will increase behavioral health care service use. To achieve our objective, we looked at 2008 through 2015 data from the Medical Expenditure Panel Survey, or MEPS. MEPS data provides information on respondent self-reported social demographics and clinical characteristics, healthcare use, and expenditures. Data data is supplemented from respondents' medical care providers and pharmacy records. MHSR allows us to discern service use events such as psychotherapy, outpatient visits, inpatient use, ER, office-based visits, and prescription drug use. Our treatment group consisted of Medicare beneficiaries with family income greater than 200% of the federal poverty level, or FPL. Our comparison group were privately insured individuals with family income greater than 200% of the FPL. In secondary analyses, we break down the groups and we look at Medicare only, Medicare plus private, and we compare that to the privately insured. We define Medicare plus private insurance as those beneficiaries with additional group coverage such as Medigap or employer-based coverage. We also re-estimated our models among only the population with mental health need. We define that as individuals with psychological distress or depressive symptoms. Our dependent variables measured out-of-pocket costs and service utilization in the past 12 months. We looked at out-of-pocket costs for behavioral health treatment. We looked at any behavioral health treatment use, any outpatient behavioral health treatment use, and any psychotropic medication fill, as well as any specialty outpatient behavioral health treatment use. We define specialty mental health as outpatient treatment received from a psychiatrist, psychologist, counselor, or social worker. For analysis, we plotted unadjusted rates by treatment and comparison groups, and to evaluate the impact of MIPA on, on out-of-pocket costs and service utilization, we use a differences in differences approach, with the pre-period being 2008 to 2009 and the post-period being 2011 through 2015. All regression models were adjusted for sex, age, psychological distress, depression symptoms, self-reported mental health, self-reported overall health, education, and number of chronic conditions. Sorry, one. Oh, okay, sorry. This is a slightly different slide, so this isn't the, anyway. Okay, so here, it's a different presentation, but okay. So here we see a table of descriptive statistics of Medicare beneficiaries and the privately insured. So here we see that about close to 38% of Medicare beneficiaries and about 18% of privately insured had any mental health treatment use. Approximately 50% of Medicare beneficiaries and privately insured were female. About 85% of Medicare beneficiaries and 73% of privately insured were of white race. About 9% and 3.5% had self-reported mental health that was fair or poor. And about 18% of Medicare beneficiaries and close to 7% of the privately insured self-reported their physical health as either being fair or poor. In this figure, we have the unadjusted percentages of psychiatric visits paid out of pocket between 2010 and 2014. As you see the mustard-colored line there, beneficiaries with beneficiaries with Medicare only, the percentage of psychiatric visits decreased from about 55% in 2010 to about 17% in 2014. During the same time period for beneficiaries with Medicare plus private, that decrease was about, I can't see from here, about 40, a little less than 40% to about 16%. And for individuals that were privately insured, during the same time period, the percentage of psychiatric visits stayed relatively about the same between 2010 and 2014. Here we have the unadjusted trends for any behavioral healthcare treatment and any specialty behavioral healthcare treatment between 2008 and 2015. Looking at the graph on the left-hand side, you'll see that the percent of Medicare beneficiaries with any behavioral healthcare treatment in 2008 increased from about 27% to slightly over 30%. During the same time period, the private only went from about 16% to a little bit too close to a little less than 20%. When we look at the next graph, we see that Medicare beneficiaries had the percent of Medicare beneficiaries that had any specialty behavioral health care treatment was about 4 point. That's supposed to be a 5, not 2 4s. So it went from about 4.5% to a little bit close to 5%, if you notice that, and about similar for the private. Here we have the unadjusted trends for any outpatient behavioral health care treatment and any psychotropic medication between 2008 and 2015. Among Medicare, if you look at the graph on the left-hand side, you'll see that Medicare beneficiaries had about 7.5% had any outpatient visit into any outpatient behavioral health care treatment in 2008, and that increased to about 9% in 2015. About during the same time period, for the private only, it went from slightly above 7% to about 8%. I can't really see from here, about 8%. And then when we look at any psychotropic medication, Medicare beneficiaries had about 25%, and around 25% had any psychotropic medication fill in 2008, and that increased to about 30% in 2015. During the same time period, the private only had about slightly less than 15, and in around 2015, it remained about 15%. Here we have our adjusted differences analysis. We see that between the pre and post period, Medicare beneficiaries had an increase of 3.41 percentage points increases relative to the privately insured for any behavioral health care treatment. And then we also found that relative to the comparison group of the privately insured, Medicare beneficiaries had a 3.1 percentage point increase in having any psychotropic medication fill in the previous year. We did not find any differences between groups on any specialty behavioral health care treatment or any outpatient behavioral health care treatment. In summary, mental health care cost sharing parity was associated with an increase in behavioral health care service use. In our primary analysis, we found a significant mental health cost sharing parity effect. We found an increase in behavioral health care treatment and in any psychotropic medication fill. Though not shown here, we did also, in our secondary analysis, we did also find a significant mental health cost sharing parity effect. Among those with Medicare only and among those with Medicare plus private, we found both an increase in any behavioral health care treatment and any psychotropic medication fill. And also, when we limited our population to only those individuals with a mental health need, we also found an increase in any psychotropic medication. In sensitivity analysis, when we look at the impact of the mental health cost sharing parity per year from 2011 through 2015, we see our findings in the sensitivity analysis match our primary analysis. Reductions in Medicare beneficiary coinsurance had a significant impact on access to behavioral health care. Policymakers hoping to improve access to treatment should consider reducing co-payments while controlling for moral hazard through supply-side initiatives. Access to specialty behavioral health care is a rare, even among those with high psychological distress and depressive symptoms. Other incentives are needed to increase access to specialty mental health care. Specialty mental health providers continue to be in short supply for Medicare beneficiaries. And incentives for increasing primary care-based mental health care may be a useful way in the short run for reducing overall unmet need for mental health care. Thanks.
Hi, everybody. Good afternoon. Thank you for joining us in this last session of the day. My name's Nick Carson. I'm a child psychiatrist at the Cambridge Health Alliance and a health services researcher at the Health Equity Research Lab. I want to thank Vicki for the invitation to join today. And my topic today will be focusing on racial and ethnic disparities in the quality of follow-up care received by youth after inpatient hospitalization and emergency department treatment. I am a co-investigator on research grants funded by PCORI and by Harvard University. Now, as you all know, inpatient hospitalization and emergency treatment are relatively common among youth with mental health difficulties and a very important part of the continuum of care. In particular, important for racial and ethnic minority youth who endure persisting rates of unmet need for mental health care. Just to give you a scope of the use of inpatient treatment in the nation, we see that there were about 150,000 hospitalizations for mental health reasons. That's from HCUP data from 2012. And there were about 1 million emergency department visits by youth in 2010 for mental and behavioral health reasons. Now, when youth leave acute care settings, there's often a fair amount of work that's been done, especially in the inpatient unit, to identify potential diagnoses, to initiate medication treatment, to connect with outpatient psychotherapy. Follow-up is extremely important for continuing the work that's begun during these visits. And the lack of follow-up, as we can see from this brief lit review, is associated with very important health outcomes, such as rehospitalization. You'll see this, this survival diagram here shows that the rate of rehospitalization at 30 days is about 9% and about 20% at 100 days. Lack of follow-up is associated with worse antidepressant adherence. And most importantly, I'd say that youth who leave the hospital and the emergency department are at great risk for self-injurious behavior. And follow-up can really help to maintain safety and keep youth safe and from returning to acute care settings again. Now, follow-up is so important that it's been enshrined in a number of HEDIS measures, the Healthcare Effectiveness Data and Information Set. You may be aware is a tool used by over 90% of America's health plans. There are 92 measures in HEDIS across 6 domains, and the ones that we'll be concerned with today are follow-up after hospitalization for mental illness, which measures the percent of discharges for which the patient received follow-up within 7 or 30 days. So they look at visits within a week and within a month. There's a new HEDIS measure, I think just implemented in 2017, which is follow-up after emergency department visit for mental illness. Very similar, percent of ED visits with a follow-up visit for mental illness within 7 or 30 days. Now, follow-up rates have been studied. There have been 2 great papers published by Fontanella and Bridge, both using Medicaid MAX data, which have told us that Black youth have 30-day follow-up rates of about 66% as compared to 73% among non-Hispanic whites. So that's an adjusted odds ratio of 0.78. And we know that Hispanic youth have a 30-day follow-up of just 25% as compared to 49% among white youth, and exact same odds ratio, 0.78. A smaller study from Wake Forest showed that non-white youth had a shorter aftercare treatment duration. And that duration is important, that we became very interested, not just in whether a patient had 1 visit within a day, a week, or a month, but how many visits did they have? What kind of treatment episodes did they have in the wake of acute care? So we expanded on the HEDIS measure by measuring adequacy of follow-up. And this is something that Philip Wang operationalized back in 2002, defining adequate treatment to be a baseline of outpatient visits, which could be a number of psychotherapy visits or a shorter number of behavioral health visits, as long as there was a psychotropic prescription that was part of that episode. And this is more reflective of the treatment guidelines that have been published by the various professional organizations in the country. So our aim for this study was to assess racial and ethnic disparities in both any and adequate treatment following hospitalization and emergency department treatment among youth aged 5 to 17. And we generated predicted rates of follow-up by adjusting for clinical need in accordance with the Institute of Medicine's definition of disparities. Now, this approach was pioneered by Tom McGuire and Ben Cook over the past decade or so as a very rigorous way of accounting for clinical need, patient preferences, clinical severity, and parsing those out with unfair reasons for differences in mental health treatment. And I have a number of references at the end of my slides. The McGuire reference here is an excellent summary of that approach. This is a paper that we published in Psych Services 4 years ago, studying the quality of follow-up among adults. Same method. So this is a way of seeing how the IOM definition of disparities was approached for follow-up among adults. Just like Mike's paper that you just heard about, we used the medical expenditure panel survey as well. We combined 10 two-year panels. That's 96 to 2015, so that's almost 20 years of data. So that's a limitation right off the bat, given that we can't account for trends in changes of follow-up over the past 2 decades. We know follow-up rates have increased, but you'll see that our sample size was still quite small, even with the number of panels that we included. And the outcomes we studied were any follow-up, which was defined as any outpatient treatment that was started within 7 or 30 days after discharge, an adequate follow-up, which we defined as at least 8 behavioral health visits, or at least 4 behavioral health visits, as long as there was a psychiatric medication prescription in that treatment episode. And the episode had to start within 7 or 30 days. This figure hopefully explains that better than I just did. You'll have the inpatient or emergency department discharge indicated in red in the figure, and then you have your first visit within 7 or 30 days, followed by a number of visits. To reach adequacy by the definition that Wang described, you want at least 8 visits, or 4 if there was a claim for a medication prescription. And then the episode ends after a period of 12 weeks without a visit. So there could have been 40 visits in an episode, or there could have been 8, but we ended the episode when there were 12 weeks without a visit. So the analysis, according to the IOM definition, involves adjustment for differences in service use due to clinical appropriateness, clinical need, and patient preferences, if you're following the model rigorously. But many of these national surveys don't account for patient preferences in how youth and families decide to access treatment. So that's a weakness of many of these surveys. We need to do a better job of assessing preferences. That will be discussed in my implications later on. The estimate of the disparity does include differences due to unjustifiable system-level factors like SES, geography, insurance that can have a big impact on the way families access treatment. And the standard errors were adjusted for clustering of multiple treatment episodes within an individual, which was quite common. The covariates included race, ethnicity, of course, which for this study were non-Latino white, non-Latino black, and Latino. And in the IOM model, there's aspects of bias, of discrimination, of experiences of racism that load onto this variable and are represented in the findings. The clinical need variables, which again are allowable differences under the IOM, included age, gender, the Columbia Impairment Scale score, which is a measure of functioning, self-reported mental and physical health status, limitation attributed to general medical or mental health, then the duration of inpatient stay, and of course prior outpatient mental health treatment. And as you may know, prior mental health treatment is the biggest predictor of follow-up. The non-need invariables were income, maternal education, insurance status, and urban residence. So the sample ended up having 215 white patients, 111 black youth, 147 Latino youth. So quite small, even though we were looking at 10 panels of MEPS data. Roughly 50% across the 3 groups, and Latino youth were significantly more likely to be lower income and publicly insured. Okay, so I'll get right to the results. These are adjusted results. These are predicted probabilities of follow-up after discharge. And we'll start with the disparities in follow-up after hospitalization. So here we see there were no significant differences across the three groups for any follow-up within 7 days or within 30 days. And you see the 30-day follow-up here, it ranges between 32% and 55%, which is similar to what we saw in the lit reviewed earlier. But when you look at adequate treatment, we found that Black youth were less likely to receive adequate treatment after inpatient hospitalization. Treatment episodes that began within 7 days were quite rare among this group. 5% of Black youth started an adequate treatment episode, and 21% of Latino youth and 18% of white youth. This improved somewhat at 30 days, but still very low for Black youth, with just 18% beginning an adequate treatment episode at 30 days, compared to 39% and 45%. Now let's look at emergency department youth. Latino youth were equally likely to receive any or adequate treatment within 7 days. And I say equally likely because the difference between white and Latino youth, the p-value on the left was 0.09, I believe, and the p-value on the right was 0.05. So close, but still not significant by our usual definitions. But the Latino rate's still surprisingly high, given that this is not what other literature have found. So summarizing, after we adjusted for clinical need variables according to the IOM definition, Black youth were less likely to begin adequate treatment within 7 or 30 days after inpatient discharge. And Latino youth were as likely to receive any follow-up or to begin adequate treatment within 7 days after emergency department discharge. Now, we talked about the sample size limitation. We also couldn't account for location-specific conditions that might influence follow-up. The MEPS does not include institutionalized youth, so those are not included in the data set. We can't account for trends in the way that follow-up may have changed over the past 20 years. But I think there are a number of policy and clinical implications here. Are there any clinicians in the room who experience receiving patients from acute settings? Not too many? A few? So you may know what it's like to have your patients go inpatient and not hear anything from the unit or not receive any call from the emergency department. There's much work to be done in improving the back and forth communication between outpatient providers and those in acute settings. So there are CPT codes that exist that will pay for a visit to coordinate the transition of care. So it might not be possible for an outpatient provider to go to the unit and sit down with the inpatient team and plan, but I think that even phone calls are rare, and in the fast-paced setting of inpatient units and emergency room settings, there needs to be more rigorous attention paid to establishing a clear discharge plan. I'm a medical director in an outpatient child psychiatry division, and we found that transition services are extremely important. So walk-in clinics are potential solutions, but it's very difficult to have your provider sitting in an office with an empty schedule, not knowing who's going to come. One approach to this is to build in urgent slots into the providers of templates, and that's what I'm working on this summer with my staff, just to build in an hour. And with enough staff, that doesn't have to be very frequent, but we'll have an hour set so that clinicians can receive a patient coming out of the ER or the inpatient unit as a bridge to the next step of a more established outpatient care. I think it's also important to explore the impact of discrimination and racism on preferences for healthcare. We have a P. Corey-funded study at our lab now that is doing just that in looking at the preferences for depression treatment, and we're finding that the experience of discrimination has a big impact on whether a family prefers psychotropics or psychotherapy, but I don't think clinicians are as comfortable with how to ask about that in clinical treatment. And then finally, support for culturally competent wraparound services, I think, can play an extremely important role in follow-up. I'm talking about intensive care coordination, in-home therapy, community emergency services teams, which exist in various phases of implementation depending on which states have had class action lawsuits that have led to those services. And we've had them in Massachusetts for about 10 years now. To have a provider who speaks Spanish or Portuguese or Haitian Creole, who can go to a family's home in the wake of an ED visit or an inpatient visit, I think is an extremely important and underutilized approach to helping ensure follow-up and improve continuity of care. This paper will be written up by Mike Flores, my colleague, and thank you for allowing me to present today, and I look forward to your questions.
Okay, great. Hi, my name is Nicole Benson, and I'm going to be talking about care for incident schizophrenia spectrum disorders, or first episode of psychosis. And I'll just preface this by saying these are extremely preliminary findings, and so we welcome any feedback or suggestions or thoughts you might have for us moving forward. Just before I get started, I have nothing to disclose. Okay. So we are increasingly learning that early intervention in psychosis and psychotic disorders is beneficial and incredibly important. We have seen this here in the United States through the RAISE trial and in other trials in Europe, like the OPUS trial. Despite this, there's an incredibly limited supply of mental health care, particularly here in the United States. For example, we have a limited number of psychiatrists, child psychiatrists, and acute hospital beds. We know there are limited acute hospital beds across the board, but particularly for children, so those under 18, there are limited pediatric inpatient beds. And then for those 21 to 64, there are limitations of another kind. There are limitations on how mental health care gets paid for, particularly for the Medicaid population, which we'll talk about in a moment. There's also limited information on the initial diagnosis of what happens when somebody's diagnosed with a psychotic disorder. There are some studies for sure, and in the US we have some that have just come out recently in the Medicaid population, but these studies have been limited to capitated Medicaid or managed care. And there's even less known for adolescents, so those younger than 18, with early psychotic disorders. So what are these restrictions for hospital-based mental health care? In the 1950s and 60s, there was a move towards deinstitutionalization and a preference towards community-based care. So when Medicaid was formed in 1965, there was a shift towards the federal government providing payments. However, because the state has always been responsible for mental health care of their constituents, the federal government wanted to keep it that way, essentially. That's sort of the rationale for why there are restrictions on hospital-based mental health care. So a term came around called the IMD, or Institute of Mental Diseases or Disorders. And this was defined as a unit that has approximately more than 16 beds in an institute that provides mental health care for greater than 50% of its patients. And this was deemed an IMD. So for example, a psychiatric unit in a general hospital is not an IMD because greater than 50% of the care in the hospital is not psychiatric in nature, but a unit in a freestanding psychiatric hospital would be considered an IMD. So there are restrictions based on whether the government will pay for hospital-based care in these facilities. And in fact, it does not, and this is the IMD exclusion, and it applies for those aged 21 to 64. And younger patients are exempt from this. Since its inception, several states have started moving towards reversing the exclusion, and ways to do that are by applying for waivers, and the most common way is the Section 1115 waiver, which you may have heard of. Massachusetts, the state where I'm from, has done this essentially in many different ways, and there are a lot of workarounds they use to reimburse care that's received in IMDs, though the effectiveness of these various mechanisms are unclear. There are other structural issues as well within psychiatric hospitals that may prevent certain patients from accessing beds, particularly adolescents. So for example, and there are adult hospital units that may have psychiatric beds that are licensed to provide care to adolescents. So some adult units may have some beds that are licensed to provide care down to, say, age 16. However, there are hospital policies in place that don't allow patients to access those beds. So even though they may be licensed, there may be no patients accessing those beds. So with this in mind, our goals for the project were to describe care patterns for those with a new or recent diagnosis of a schizophrenia spectrum disorder, knowing that inpatient psychiatric bed availability differs across age groups, and that there may be restrictions around Medicaid reimbursement for mental health care, and then to compare care patterns in different age groups and those who have a schizophrenia spectrum diagnosis among patients with Massachusetts Medicaid. So we're using the Massachusetts All-Payer Claims Database from 2009 to 2013. We identified Medicaid beneficiaries between the ages of 14 to 35, and we used the ages 14 to 35 because this is most commonly when schizophrenia presents. It presents a little bit younger in men, so around 14 to 25, and a little older in women, 25 to 35, and we wanted to be sure to capture both first episodes in men and women. We then tried to identify the first episode, and so we did that by using either one inpatient or emergency department encounter or two outpatient encounters that occurred within 1 year of each other, where the diagnosis was a schizophrenia spectrum disorder, and then ensured that there were 12 months prior to the diagnosis without a previous schizophrenia spectrum disorder or an antipsychotic prescription. We then focused on care episodes for 3 distinct age groups, and the age groups were 14 to 17 years, with the knowledge that, or the belief that they would have limited access to adult beds and would only be able to go to a pediatric psychiatric inpatient unit. The 21 to 35-year-olds, with this idea that they might have, though they have access to adult beds, they likely have limitations around Medicaid reimbursement, or at least there's a question mark in our heads. And then the middle age group, so this 18 to 20-year-old age group who certainly has access to adult psychiatry beds and have no restrictions on Medicaid reimbursement. So our study population is about 9,000 adolescents and young adults. The majority, of course, are in the 21 to 35 because it's the widest age range, and you can see on the graph that there's a sort of wide distribution of ages, and they're a little bit fewer than half were female. And we went to look, where was the initial diagnosis? So our first question was, where are they getting them? And there were 3 main buckets that we were interested in: the outpatient setting, the inpatient setting, and the emergency department. And you can see that the majority of these young adults are receiving their diagnosis in the outpatient setting, but it does vary. And just to note for how these buckets are stratified, if someone presented to the emergency room and received a diagnosis of a schizophrenia spectrum disorder and then was admitted to, say, the inpatient unit, if they received the diagnosis in the emergency department, they would be classified as the emergency department for the purposes of this analysis. So we then looked to see if there were differences, and using the 18 to 20-year-olds as our reference category, we found that those who were in the older age group, so those 21 to 35, were significantly less likely to receive their initial diagnosis in the emergency department or in the inpatient unit, and significantly more likely to receive their diagnosis in the outpatient setting. And that the younger group, so those 14 to 17, there were no differences when compared to the 18 to 20-year-olds. So that was just for the first diagnosis. So we're next interested in what happens after the initial diagnosis. So the first thing we're interested in is hospitalization. So we started to look at hospitalization within 6 months after the first diagnosis. And what we found is that within 6 months at 6 months, the those who were older, so 21 to 35, and those who were younger, 14 to 17, were both significantly less likely to be hospitalized than the 18 to 20-year-olds. So to me, this is sort of interesting because we have this group, the 18 to 20-year-olds, and they have access to the adult beds. They potentially have no restrictions on Medicaid reimbursement, and they're more likely to be hospitalized within 6 months of their incident diagnosis. At the same time, hospitalization is sort of a tricky outcome because we can't tell, particularly from our claims data, whether this is a worsening of their disease or whether it's good care. And you can see when we remove the incident diagnosis, so say they were hospitalized for where they received their diagnosis, that finding disappears for the older age group but remains for the 14 to 17-year-olds. So I think this is where we started, and certainly we're interested in looking at many other things that might tell us more about what's happening after the initial diagnosis, like are they receiving antipsychotic prescriptions, are they seeing psychiatrists, all of which might help us understand, is this disease progression, or are they receiving the care we might hope that they are receiving? Certainly, though, there are a lot of limitations to this study and a study like this. I think first and foremost, the true definition of a first episode of a schizophrenia spectrum disorder in claims data is undefined, and we continue to refine the cohort specificity and the definition as we go. I also think that using claims data, the severity of illness is difficult to pinpoint, and that particularly for what we're studying here, the location of diagnosis probably, particularly the first diagnosis, probably is affected by disease severity. So I would imagine somebody who might be sicker might be more likely to present to the emergency department. Maybe somebody who's doing better might present to the outpatient setting, or someone who has family might be more likely to get them to the outpatient setting. So I think there's a lot of stuff to untangle here. And then in particular, in Massachusetts, it's been challenging to uncover the specific details regarding the Section 1115 application waivers and sort of the workarounds around what's been going on with Medicaid. And so we're working to understand that better. What I think we can say, though, is that most patients with new onset psychosis in Massachusetts receive their diagnosis and care as outpatients, and that patients under the age of 18 and over 21 are less likely to receive care as inpatients than those in the 18 to 20 age group, particularly within 6 months of being diagnosed with a schizophrenia spectrum disorder, suggesting that psychiatric hospitalizations may be constrained for the treatment of early psychotic disorders, and that we certainly need more work to understand the impact of early care patterns and what this means. Thank you.
While we transition, I want to thank Vicki and her colleague Ben Cook for organizing this great symposium and inviting me to discuss these great papers. So first I need to give a few disclosures. As a Fed talking about policy levers in particular, I need to give the standard agency disclaimer that the views expressed here are my own and not AHRQ or the rest of the Department of Health and Human Services. I'm also listed as a co-author on the floors or Mike's paper. So it's a little unusual for discussing to discuss his own paper, but it's been a few months since I've actually seen the paper or results, so I'm somewhat coming at it fresh. And I also should mention that I'm co-authoring on current projects with overlapping subsets of co-authors on all four papers, so sort of the Rockville satellite office of Cambridge and Boston. So I might have a biased opinion, but I think they're great researchers doing great work, and what you've presented here. So the challenge here today is to put together 4 different presentations. 2 of them are easy to put together because they're talking about the same policy. The other 2 we're talking about widespread of mental health policy to look at. So what I thought I'd do is do a brief summary of what we've learned from the 4 studies, and then walk through each of the studies one by one to talk about some puzzles and some suggestions for some deeper dives. I'm going to go against the grain of my economist training and not focus so much on methods, but more on interpretation of results and sort of interesting things or strange things that I found. All these studies were methodologically well done within the limits of the available data. And then at the end, I'll come back and talk about some policy levers, depending on how much time we have. So, we've got large gaps, as we all know. Few people are low screening rates in the population. Less than 50% of even the severely mentally ill access any kind of mental health treatment during a year. And the care is often inadequate along a lot of different dimensions. And of course, there are very large differences by race and ethnicity, when we've seen on some of those dimensions here today. So what we learned about about policy levers and how to address these gaps here, and we have a lot of work to do. Mike and Vicki's papers using 2 different data sets to come at the same basic question about what the effect of reducing demand-side cost sharing to parity levels in the Medicare population. And we find a consistent set of results that there's increased use in both studies, reduced out-of-pocket burden, that's consistent with previous work on parity, increased access on more people using treatment, reduced disparities, good news. But this policy by itself is insufficient to eliminate these large gaps. So it's incremental changes that we see here. The Benson Nicole study, going in a slightly different order here, and it focused a lot on sort of supply side factors in explaining hospitalization rates and initial diagnosis for incident schizophrenia spectrum disorders. She focused on limited supply of beds and service providers for those under 17, and for the 21 plus population, the Medicaid should be IMD exclusion, not the IMDb. I think a Freudian slip that I'm overdue for a summer vacation to catch up on releases. And then Nick's study sort of has talked about policy implications on both the demand and sort of supply side that for addressing racial and ethnic differences or disparities in receiving adequate treatment after inpatient discharge. Not surprisingly, consistent with previous literature, black youth were less likely to receive adequate treatment after inpatient and ED discharge, but some evidence that Latino youth were actually more likely to receive adequate treatment after ED discharge, which is a pretty surprising finding. Okay, so turning to Vicki's study first, and I had the most questions about this one, or puzzles. So the big increases sort of coincide with the smallest changes in coinsurance rates. So when you move from 2009 to 2010, that's a 5% change, but you've got a big increase. And then subsequently in 2014 to 2015, there's no change in the coinsurance rate, and you've got this big jump again, and in between, it's sort of flat. And so that's a little hard to explain, both in terms of reducing coinsurance, and it's also, you might think of a story in terms of leads or lags, anticipating a policy or taking some time to adjust, but looking at the beginning and end periods, they work in different directions. So I was a bit puzzled by that. And then I was also puzzled looking at the bottom quadrant on the non-physician providers that you saw a decrease in use. And I would have thought that primary care provider use and psychiatrist use would be less price sensitive than non-physician providers providing cognitive behavioral therapy or other therapies. So I would have expected that reducing coinsurance rates from 50 to 20 to intensive CBT or other kinds of treatment through social workers, psychologists, and other counselors, we would have seen an increase, not a large decrease. And then you also see this big, almost immediate change with just a 5% change in the co-insurance rate on primary care physician use among blacks, and then also similarly, almost instantaneously, change with a small change in the co-insurance rate in Hispanics jumping to facilities. So that really begs the question of, is this the co-insurance rate that's going on, or are there other things going on simultaneously in the policy arena, or sort of secular trends, or something that explains this big jump? Okay, so just a couple of other random questions that they could look at is to look at how much of the increased use is driven by new users versus greater intensity among current users. Other question I have, always looking at claims data, is how are primary care physicians coding visits that are related to mental health treatment? And if their patients are now receiving only have to pay 50% or 20% out of pocket as opposed to 50%, they may be more willing to code mental health visits or depression rather than putting diabetes as the primary or only code on the bill. And then also, what were the potential impacts on psychotropic medication use? So turning to Mike's study, which is using the world's greatest data set, the Medical Expenditure Panel Survey, or MEPS, which I work on, so slightly biased there. The one sort of puzzle I had, or the thing I noted is that, and Mike noted this as well, is that the baseline use among the treatment group was almost twice as large as the control group. And you find a difference in this, but this could be driven by the same proportional increase in both the experimental and controls. And so it's a sort of a bit of an interpretation of whether you do difference on levels or percentage change, something to think about. And the other thing I noted, stealing again from their slide decks, is that when you look at the overall population, you see increases in both use of any behavioral health and then any specialty care. But when you switch to those in mental health need, really if you wash out the middle period, there's not much change in those identified as having mental health need, suggesting that the increases in use are coming from those with subthreshold symptoms or no symptoms. So that's, I think, something to explore, because there's certainly issues about target efficiencies of policies to improve access to mental health treatment. So switching to Nicole's study, looking at the Massachusetts all-player claims data, she's our most recent study, but she focused on the IMD exclusion as being an interpretation for why the 21 to 35-year-old group might be have less hospitalizations than the 18 to 20-year-old groups, and then again the constrained supply of the 14 to 17-year-old group. But I really wonder a couple of things. One, Nicole already talked a lot about whether the inpatient setting is really the best place for initial treatment, diagnosis, and treatment. But I really started thinking about this in a couple of contexts. One is, and Nicole alluded to this, that the people who are in the 21 to 35-year-olds have had a much longer time or exposure to and potential to have developed the true incident case of schizophrenia, and could have had visits that are outside of the claims database or other hospitalizations outside of it. They're just much more likely to have for that to have occurred, and potentially they're already connected into or can go back to the mental health system, unlike someone who's 18 to 20 who's just getting or has their first psychotic episode. The other thing I wonder about is sort of the selection into Medicaid coverage, because the 18 to 20-year-olds are an interesting group. They're transitioning off of their parents' coverage in some cases, maintaining coverage that they had as when they were a child, or their CHIP coverage, or they might also have a new incident of behavioral health issues, and schizophrenia might not be the first behavioral health issue that they have that leads them to get onto Medicaid. So there may be some selection issues going on that make these a more severe group. And one thing I thought you could do is, because it's an all-payer database, is to look at the private population, obviously. And then the last piece is going, again, to the world's greatest data set, MEPS, but exposing perhaps the not greatest part of it is that, for certain types of conditions and, particularly more the seriously mentally ill are probably underrepresented in the MEPS, and finding enough sample of people who had very acute episodes requiring inpatient or ED visits is a challenge, particularly in fairly narrow populations, and trying to split it up by race, ethnicity. So he does the best that he can there. So I wondered about the Latino population in particular, since that's big demographic changes in that group, especially over 96 to 2015. And I also wonder whether this is a severity issue that you're not really picking up with the other health status measures, simply that Latinos lack this, are much less likely to have behavioral health treatment in the first place, and so when they get to the point of needing acute care like that, there's much more of a problem, but they're already plugged into some kind of mental health treatment system. And then just finally, and try to avoid getting too much trouble talking about policy, but in terms of policy levers, we pulled a lot of policy levers to address mental health over the last decade, 2 decades. The standard toolkit, at least from an economist standpoint, is insurance and financing. So the 2 studies that looked at the Medicare parity is obviously a classic case of that. And here, consistent with the parity in private health insurance coverage from the 2008 Domenici-Wellstone Act, you do find reduced out-of-pocket burden and some evidence of incremental improvements for some populations, but it's not earth-shattering. It doesn't solve all those issues. There's just so much more going on outside of the insurance and financing box, which is somewhat easier to define and to study, but may be not the most important drivers, which is not to say insurance and financing isn't important in driving, in supporting other types of policies, levers that close these gaps in a more substantial way. So, thank you.
Is this on? Okay. Well, thanks, Sam, for wrapping up all these papers together and kind of asking some really good questions about the approach and the findings and the implications, and I think also tying them together from a policy perspective. That was really helpful. I think in the interest of time, maybe we can just each take just a minute to kind of maybe hit the high-level points of some of the things that you brought up in your comments. If each of you guys want to address anything that Sam raised, I can start. There were a lot of questions on my study, and I agree. We have a lot of meetings where we start off with, well, these are really interesting and kind of hard to explain. And I think the first issue around sort of the lack of gradient associated with the gradual phase-in of the cost-sharing reduction is something that's been kind of vexing. And, we would like to see a really nice sort of increase in the visit rate that parallels the reduction in the cost-sharing rate. And that's just not what we see. And I think, like you said, that maybe there are some lagged effects that can explain the 2015 findings, but the early findings are a little bit trickier because it's a really small increment in terms of the cost-sharing reduction. I think things that we're trying to look into are sort of other maybe changes in reimbursement that are happening around the same time. We think that our identification strategy is hopefully pretty good at picking up maybe some of the concurrent policy effects, but I think that there are some, we found, at least for psychiatrists, some reimbursement changes around this time, which could impact use. Let's see. Yes, new users versus greater intensity, which is stuff we're trying to tease out now by sort of looking at folks who come in already with a mental health diagnosis versus folks who are newly diagnosed once the policy changes. And then the PCP coding thing is a really important issue. And we've looked also at sort of a different definition of mental health visits to primary care providers where there's not sort of a claim line with a mental health diagnosis, but just any mental health diagnosis on the claim summary, which is a little bit, gets into the weeds of how claims data work, but we see similar patterns, but just much smaller magnitudes. So we don't see a big change in the way that PCPs are coding in terms of whether they're adding a mental health diagnosis to the claim for folks who have any diagnosis on the claim summary, but it's a really important issue, and I think that there could be some provider behavior things. And trying to tease out those provider behavior things is also, I think, an important piece of this, because this policy change could also impact how much the providers receive when they provide these services. So, Mike, do you want to address anything that Sam brought up in the comments?
I think a point that I thought was pretty interesting, which is good, what I thought was you would imagine that the population that needed mental health need would probably, once you start decreasing the cost share for them, they'd probably use services more. So I think it's to really understand as to why that population didn't increase, whereas the population with probably not the same symptomology has increased services, I think is something that we should probably really delve into and really understand as to why that works out that way.
Nicole or Nick, you guys want to respond?
I don't have much to say because I thought all of your points were excellent, and certainly things we've thought about for sure, particularly like why these young adolescents and young adults have Medicaid and what that means about the results and how we can tease that out a little bit more, I think is a particularly important point. As you mentioned, the benefit of the all-payer claims data set is that we can look at commercial insurance, which I think we intend to do, but I think that's something that we have to keep in the back of our mind for sure. So thank you for that.
And thank you for your comments on my paper. The best data set in the world allows a lot of variables around clinical need and then the other so-called non-need variables. Geography is in there, and we noted that Latinos in our sample tended to be more in the Northeast, where access to care is better. So we wondered if it was a function of increased availability of services that might help to explain that difference that we found with Latinos after ED.
Well, we still have a few minutes for the troopers who have remained with us to the bitter end. So please come up to the mic, and if you just introduce yourself and ask away. Thanks.
Hi, I'm Marcela Horowitz-Lennon with RAND Corporation. Excellent presentation. Congratulations for the work. Had a comment to Nick about the sort of interesting finding about Latinos having a better result with follow-up, and I was going to comment on the possibility of geographic differences because they tend to concentrate in certain regions of the country. And the other thought was whether there's any way, and maybe you are looking at this, adjusting for the presence of family and there being sort of a social network that they can rely on and who sort of pushes from behind to get them into clinic. And Nicole, I was wondering about the diagnosis of schizophrenia as a first diagnosis. As a clinician and researcher, the evolution of diagnostically tends to be trickier, and people don't usually get a first diagnosis of schizophrenia right off the bat. So whether you've looked at psychosis not otherwise specified, or sort of psychosis and substance use as sort of forerunners of that schizophrenia diagnosis.
I think that's a great question. So we're including unspecified psychotic disorders as a schizophrenia spectrum diagnosis. in our analysis, but I think it's an excellent point because particularly, so I'm a child psychiatry fellow, and what I see with kids particularly is that they can start with a very different diagnosis other than schizophrenia. It can start with bipolar disorder or something totally different and then evolve. And as of right now, we're not capturing that. And so I think that is something to keep in mind as we move forward, because I think it's true, we aren't. It's a much cleaner analysis right now, but that is something we're clearly missing. So I thank you.
I'd also just say, just on with the APCD, when we could, we've sort of identified folks who have 12 months without a schizophrenia diagnosis and then receive one, so we can look back and just sort of see what the patterns of coding were too in the diagnoses that were given to this population as well, preceding the initial diagnosis. Yeah. Go ahead. Go ahead.
Thank you. I'm Andrew Carlo from the University of Washington. I just wanted to ask a question to Michael. Wondering, when the parity came into place for Medicare, do you know anything about the impact that had on providers? Because I can imagine, psychiatrists seeing a patient knowing that their cost-sharing percentage is so high, it might deter them from even engaging with Medicare networks. I'm wondering if there was any impact on psychiatrists participating in Medicare networks as a result of this change.
I can't speak directly to if that increased or not. I could just speak to I don't know if Vicki has some kind of
Well, we've actually tried to look at this. So, the work that Michael and I presented is all part of the same project. So using the claims data, we've actually been interested to see whether this policy change is associated with sort of a greater participation in the Medicare program among psychiatrists. We just started with psychiatrists. And we don't see a big change in the sort of proportion of psychiatrists who are participating over time, or the per capita number of psychiatrists who are participating in the program over time, which we're just basing on whether they have, a minimum threshold of claims for Medicare beneficiaries. But it is a mechanism that we thought might operate in terms of improving access to care, is that more providers might be willing to provide care to Medicare beneficiaries, especially on the specialty mental health care side, where participation rates tend to be quite low to begin with. Yeah. Great. Well, I'm not seeing any other questions, but thank you all for coming, and I hope you have a great evening.